So I'm traditionally the troublemaker, so I don't stick to script. So I was given laparoscopic rectopexy. I don't do laparectopexy, I do robotic ventral mesh rectopexy. So I thought I will give you an overview on what's happening in rectal prolapse, and and then we'll show you some videos on robotic ventral mesh rectopexy and take it from there. All right? Okay. So rectal prolapse essentially means full thickness rectal prolapse, which is the entire rectum protruding through the anus. Mucosal prolapse is only when the rectal mucosa is prolapsing. And then you get internal intussusception, where the rectum collapses but does not exit the anus. So etiology is unknown. It's more common in women, although in the subcontinent we see lots of young men. Majority of our practice is young men with rectal prolapse in the 20s. Children also have full thickness rectal prolapse due to constipation, excessive straining. ODS and constipation is also shown to be part of the etiology. Elderly because of weakened sphincter and pelvic flow, probably related to childbirth. Hysterectomy and solid rectal ulcer. When you look at anatomically, what are the findings when you assess rectal prolapse? Is that there's an abnormally deep pouch of Douglas, a lax and atonic muscles of the pelvic floor and anus. There's weakness of the sphincters, often from pudendal neuropathy and usually secondary to childbirth. And there's lack of normal fixation of rectum with mobile mesorectum and lateral ligaments. So how common is it? It is uncommon but underreported probably, particularly in countries where it's culturally not, it's not usual to go and speak to someone about these things. It's very much the case in the subcontinent. Most 80 to 90% are women. Associated features of 50% will have incontinence, and a major proportion of them will also complain of constipation. And often there's concurrent pelvic floor descent, prolapse, and other pelvic organs, and so that's why these conditions are managed part of a pelvic floor unit. So 35% of patients who present with rectal prolapse are also nulliparous. So, it is quite complicated, the etiology. The clinical feature: prolapse during defecation with bloody mucus discharge, or just mucus. Fecal incontinence reported, constipation or incomplete evacuation also reported, and then some levels of pudendal neuropathy as well. I think the most important thing is a good assessment. I think good history and physical examination is so very important. It's ideal to ask the patient to demonstrate the prolapse in the office couch. You can ask them to lie inside and ask them to strain. It's not really effective. They need to get into that position of straining on the toilet. And often these days, patients come with their cameras and cell phones with the pictures on. Taken pictures of their prolapse at home. I think it's good enough. I think a common pitfall is differentiating between prolapsing internal hemorrhoids or rectal mucosal prolapse, and I think that's very important. You need to make sure that it's a full thickness prolapse. So if you look at it closely, you'll be able to assess the direction of if it's concentric, the folds, and it's usually a full thickness rectal prolapse. Assessment, okay, you can do proctoscopy and you might see a solid rectal ulcer anteriorly, and ask patients for a photograph of the prolapse at home. 20 to 35% of these patients, 25 to 35, will complain of urinary incontinence, and a proportion of them will also have other multi-organ prolapse. Evaluation, defecography. It shows associated defects such as cystocele and vaginal wall prolapse and intraceals. Colonoscopy and sigmoidoscopy is very important to make sure there's no tumors, associated tumors which are causing the prolapse. Rare but can happen. Manometry will give you an idea of how effective the sphincters are, and marker studies will help you differentiate if it's a slow transfer constipation. And neurodynamics are used selectively depending on if patients have urinary symptoms. So aims of treatment are to correct the prolapse, protect or restore continence, and avoid constipation. We need to avoid any further damage to the nerves and try to give them a procedure which is of low morbidity and low recurrence. Now, it could be either resection or application of the redundant bowel or fixation of the rectum to the sacrum. That is the primary principle in how you deal with these things. So is there a role for non-operative management? The answer is no. If they come with a thrombosed rectal prolapse, it can happen. It's very painful. We need to alleviate the pain, give them some stool softeners, and give a bag of sugar to put on the bottom so that the swelling comes down. Attention should be paid to the skin around the prolapse because normally there's a lot of erythema and itchiness and discomfort. And if fit, I think we should encourage these patients to undergo early surgical intervention. So surgical management, as you know, is complicated. Well, it's not complicated because we don't know what is the best procedure because there's so many and none of them are, is a gold standard. So the usual challenge is whether we do an abdominal procedure or a perineal procedure. Now, I think you choose that based on the comorbidities of the patient. If it's a very old or frail patient, lots of comorbidity, you use perineal procedures. Surgeon preference and experience, that again, it's very important that surgeons, use the procedure or choose the procedure which they're well versed with, because you don't want to try something, once a year, twice a year, and I think that's very important to whichever works well in your hands, lap, robotic, open, abdominal, perineal, doesn't matter. What works for you and gives the best results and low complications, choose that procedure for the patient. And patient age and bowel function is important because you want to know if the patient's got a history of constipation, then you may recommend a resection along with it. And then again, pelvic dissection, whether you want to do a posterior dissection or just a ventral rectopexy to avoid damage to the nerves, which we'll touch on later. So abdominal procedure, basically all procedures, there's a transabdominal approach. You fix the rectum transabdominally, shown to have better functional outcomes and lower recurrence. It's all retrospective data. There are three Cochrane reviews done, 2000, 2008, 2015. All of them showed no difference between abdominal or perineal procedures. Again, patient selection bias could be one of these things. The patients usually select perineal procedures are older, less healthy patients. For the abdominal procedures, choice-wise, there's no clear evidence. Careful consideration should be given to improving patient function with least morbidity and sustainable outcomes. Whether you want to do posterior ventral, but again, looking at the literature, there's no difference or superior outcomes. Recurrence is roughly about 10% at 10-year follow-up. So we'll just go through what's been done and roughly give you an oversight. Ripstein's operation is a posterior mobilization of the rectum, and then mesh fixation of the anterior rectal wall to the sacral promontory. Recurrence rates about 4 to 10%, and complication mesh related up to 40 to 50%. And so that's why not widely practiced these days. Modified Ripstein's, where there's posterior fixation of the mesh to the sacrum, attachments of the ends of the mesh to the rectum laterally and avoiding the anterior fixation. Recurrence rates of 2 to 5%, 20% postoperative morbidity rate. Most of these are minor complications. And mesh rectopexy results in significant improvement in fecal incontinence, 20 to 60%. The posterior suture rectopexy is widely practiced. It's simple, it's easy to do, and it's recommended because of the ease of the procedure. Suturing the rectum to the sacral, mobilizing the rectum and suturing the rectum to the sacral promontory aims to prevent the further telescoping of the redundant bowel. And you try to use a permanent suture. And the way the rectum sticks up is due to scarring and fibrosis because of the posterior dissection. Recurrence rates of 3 to 9% at 2 years. And there was a study from the rectal prolapse recurrence study group at 10 years recurrence rate are about 29 to 30% with this technique. Posterior, and also with the posterior rectal mobilization, you can produce or worsen constipation. This is probably people are worried about, or technically whether you may damage the nerves which are running posteriorly. 50% of the patients with pre-op constipation, their constipation is worsened after rectopexy. 15% of these patients with no pre-op constipations develop new constipation. Sigmoid resection may be added with prolapse surgery or pre-op constipation. Patients complain of these two things, and then you can add a sigmoid resection. Recurrence rates are 2 to 5%. Major complication rates are 0 to 20%. As there's no mesh, it's an easy operation. Resection of the redundant sigmoid colon avoids. Again, we've shown that we've seen that there is less constipation once you resect. But division of lateral stalks during posterior rectal dissection may worsen post-op constipation, but there is an associated decreased recurrence. So why do you get constipation with posterior rectopexy? The theory is that if you fully mobilize the rectum, you can potentially damage the autonomic nerves which are running posteriorly, and this will result in dysmotility or impaired evacuation. So that's when Dehor and his colleagues described this technique of ventral mesh rectopexy in 2004. Essentially, you mobilize the anterior wall of the rectum, avoiding lateral posterior dissection. with the hope that you avoid nerve damage. And you fix the mesh to the anterior wall of the rectum and then fix the mesh again to the sacrum. You hoik it up and then fix the mesh rectum. So indications for ventral mesh rectopexy are full thickness rectal prolapse or an internal prolapse or interception, which is a new indication. Some case reports have come across. So I'm just going to show you some videos. So the first thing is, opening the peritoneum so that you can mobilize the rectum anteriorly. At this point, because of the chronic prolapse, you'd see that it's a very redundant peritoneal folds, and then you'll also see these nerves which are also fibrosed and sort of pulled up. So you need to be very careful when you open that dissection. It's not going to be like an anterior dissection where you open up, the nerves drop down, and so you need to be careful. So the nerves are just there. So you need to be careful when you because the whole point of the operation is to try to preserve these nerves and not damage them. So the nerves are just there. They're sort of little tented up. So you need to drop those nerves down. So this dissection again, the sigmoid colon's there. This is the pelvis. The IMA vessels are here, just to give you a context. So the promontory is just here.
What is your method of choice for rectal prolapse?
Now, ventral mesh rectopexy.
Ventral.
I know the results of what we've seen are all short term, and there are some issues with it, but with the ease of operation and I've been doing it for 3 years now. I've so far had major issues. But again, if papers come out questioning mesh complications or then we may have to.
One of the main concerns with ventral rectopexy are even by Andrea Dor and others, mostly in Europe, painful intercourse. Like with the vaginal intercourse, that the mesh in that septum, rectovaginal septum, may cause a lot of pain.
Sure.
Is that a concern in your practice?
Yeah, absolutely. So as I said, I was saying earlier, majority of the people I deal with are young males. Of our 70% are young males who have this. But again, we talk to them about mesh complications, particularly women, young women. We talk to them about all these issues which are there, but also talk about why this technique is recommended, and we essentially ask them to choose. Although we say this is our preferred choice, but the choice is given to the patient. It's very important because that's clearly documented, because we still don't know what's the right technique. So once this peritoneum is opened and you want to do for anterior section I was telling you earlier, we pass a straight needle and to hoik up the peritoneal fold so that it opens up that space nicely. Again, this is a young male. So you could do the same thing for when you're doing anterior dissection for rectal cancer work. It just opens up that plane. You'll see that in a minute. So you continue the dissection anteriorly. So it's just peritoneum opening up, clearing the sacral promontory where you want to fix the mesh, and then just you go all around. As with rectal cancer and this for rectal prolapse, where do you make the anterior point of open up peritoneum is about 1 to 2 centimeters. I use 2 centimeters from the between the rectum when it takes the fold. You shouldn't go the fold comes the rectum and the peritoneum. Not in this junction. You need to be about 2 centimeters above so that you can get into that plane. Okay. So the next step would be to do the deep part of the pouch Douglas. And then I can carry on with the anterior dissection. So here I was in the wrong plane. So as I was telling you earlier, this fat stays with the rectum. So, because of this chronic prolapse, I wasn't too sure where the dissection pointed. Then we identified the right place. So that's what. So when I realized when I dissected, it was the fat was going up and I was onto the rectum. That's the wrong plane. Fat always stays with the rectum, so that needs to be anterior to it right here. And that's the same principle even in rectal cancer as well. So you carry on with the dissection and, with right amount of traction. So again, with the robot, I think getting these views are very good. You can get really deep and put the right amount of traction with your left hand so that you can, carry the dissection right up to the pelvic floor. The same thing can be achieved laparoscopically too. And I think it's important to take your time because of the chronic prolapse, sometimes these tissues are so thickened and not very clear. So take your time, just get that, you can see that nice angel hair fibers there. I think it's very important to be in that plane. If you're in a hurry, you might just get into the rectum and then you really can't do much later. So you carry on with the dissection. I'm just going to fast forward that.
So in your practice, you see more male patients than female patients
Yeah, absolutely.
with rectal prolapse?
Majority of them, young males.
That's interesting.
And all from the north of India, north and northeast of India.
Do you know what might be the cause of that?
Paper to write, research to do.
But you do have female patients too.
We do, but proportion of them, I don't know. I mean, that's my worry is whether they even come out and talk about it.
And you do ventral rectopexy for female patients.
So I'm saying, so I do ventral for everyone, but I explain to the patient very clearly, and if they're not happy with that, then we do a suture rectopexy.
And then where do you saw the mesh in females as your lowest point?
Same.
Coming. Oh.
Same place. It'll come.
Okay.
So I'm just going to move on. So then you introduce the mesh. Then again, the mesh is we've used all types of mesh. We've used a proline mixed with Weichel mesh. Then we've used a biological mesh. If you look at the literature, there's no difference in these things. But this was because you can see the suture points. So I thought I'll just show this video. So you need to take 6 suture points. The mesh needs to sit at the lowest point, of the dissection. That's right on the pelvic floor.
Very good surgery, Dr. Munikrishnan. So I'm wondering, are you using any vaginal or rectal bougies to ease dissection down to pelvis?
Yes, that'll really help, because it's again, as I said, this chronically prolapsed tissues, they're so thickened, and sometimes these spaces don't open up, and it really helps. I'm just going to speed that up.
And wondering if you adding any resections, like colonic resections in addition.
Yeah, if there's a good, strong history of constipation, then you add a colon resection with it.
Okay.
But again, if I wouldn't want to put a mesh, if I'm doing a resection, then I would do a suture rectopexy.
And you use a permanent mesh.
Now we move to proline, standard proline. So I'm just gonna. So that's one stitch. So you put 2 paddles, side by side, 2, 4, and 6. So as you can see, 2 stitches there. Then you put another 2 there, and then another 2 here.
And what is the suture you're using?
Again, we've tried also, we do it at the bond, and now we use proline, true proline.
What problems did you have with Etiban?
No problems. It's just that,
More
you know,
expensive,
visited the Oxford guys. They said tuoproline works very well. And if it's good for them, it's good for us, I guess.
I mean, proline is monofilament, so
Yeah.
it's a little bit harder to suture, whereas I think Ethibond is softer, easier to handle.
Yeah. But with the robot, I think it compensates a bit, I
Yeah.
suppose. So that's 4 done. Sorry.
Salondan herhangi bir sorusu olan varsa şimdi uygun bence sorulabilir.
So now that the suture, no, this was a proline vical mesh, but now we use proline mesh and use tuoproline to stitch as well. And then you hike up. So 1 minute. So it's important, you know, when you're fixing the mesh to the sacral promontory, you need just enough tension so that it's like a, you know, so that the rectum sort of has a gentle arch. You don't want it to be, you know, really tense. You know, it just needs to hold it, you know, so the rectum comes like that, so that there's enough tension to hold it that it doesn't prolapse down, and then you fix it. And I think that's an important point. Use standard tacks to make sure, put 2 or 3 of those so that it's.
Do you use those tuckers routinely for sacral fixation?
I've used sutures as well, and it depends. I mean, we're trying to avoid more and more
Any
suturing.
change in the outcomes in terms of pain using suture versus tuckers?
Yeah. So there are 1 or 2 patients who complain of back pain. So we do more suturing now. Okay.
Because original technique also with the tuckers, so.
Yeah. So then we close the peritoneum. We use a V-lock suture.
And you use VLAP, right?
Yeah.
Would you like to comment about laparoscopy versus robot, especially for those kind of operations
I think.
in the deep pelvis?
Yeah. I think you know, suturing and dissecting deep in the pelvis, up to the pelvic floor, I think the robot helps. But again, if you're a good laparoscopic surgeon, you know, you could do it very nicely. So, yeah, probably I'm not as good as Emery or you. So, I just find it helps me in my practice. So I use it. But I mean, the same principle of laparoscopy applies for all these things. Is if you know, if you use technology, and if I mean, whatever works in your hand, use it. You know.
I think robot is ideal for suturepexies. I mean,
Yeah.
it's the perfect.
But you can do
approach.
this same effectively laparoscopically. I used to do it laparoscopically. It's just putting the first 2 sutures deep in the pelvis. It's challenging. Otherwise, the proximal ones are much easier. So basically, you exclude the mess from the pelvic peritoneal abdominal cavity by closing the pelvic peritoneum. So essentially, just the entire thing is excluded.
Venky, could you wrap up?
Yeah. Okay, so that's that. So conversion rates with lap ventral mesh rectopexy are about 2.9%. Mesh complications are low, it's 1.2%. There's no difference between synthetic and biological mesh. Recurrence rate at 23 months is about 4.7%. There's constipation, and also there's some worsening, and there's a 31 to 84% incontinence improvement. Recurrence rate again with LVMR is 1.5 to 9.7%. Again, it's very variable follow-up and reporting. There's some papers on robotic ventral mesh rectopexy. There's similar recurrence rates. Mesh-related complications are rare again. About 4% is what has been reported. So I'm just gonna quick look at perineal procedures. Delomes again, old patients. high-risk patients, I think use a Deloms, and it's a good operation for, particularly in the old and elderly, or those with comorbid. Recurrence rates are 10 to 15%. Patient selection is very important, and there's improvement in constipation, fecal incontinence, and urgency. And tenesmus has been reported. Perineal sigmoidectomy, the Altmaier procedure, transanal full-thickness resection of the prolapsed rectum, and a cholanal anastomosis involves shorter hospital stay, lower complication, but recurrence rates are 16 to 30% at 2 years. But again, you can decrease the recurrence with levatoplasty. So there's a PROSPER trial, which is only randomized comparing surgical treatment rectal prolapse, which basically said there's no difference in any of these treatments. So we still don't know what's the best technique. So, I'm not going to explain this, but you need to have an algorithm to work out which patient you're going to choose. And there are guidelines from DCR to, if you want to read it up later. Thank you.